Hey everyone, as promised, I'm going to do a quick overview of some of our psychotropic medications. This PowerPoint does have a few meds I'm not going to talk about today. I'm going to focus on anxiety, depression, and schizophrenia. So we did this in Unit 2, quick overview, psychotherapeutic medications. They work by affecting the neurotransmitters in our body. They are not affecting the psychiatric diagnosis, they're affecting the brain. We have some of our more common neurotransmitters, some of the ones we've talked about these last few units. GABA for anxiety. GABA is inhibitory. Large amounts are calming. Low amounts of GABA produce anxiety. Dopamine pleasure. Dopamine is also involved in schizophrenia, hallucinations, depression, Parkinson's, right? Low amounts of dopamine are Parkinson's. Serotonin is one of our big ones for mood. Low levels of serotonin is depression. So we have a bunch of different classes of medications. We are specifically going to focus on, honestly, most of these. We're going to touch on a few, especially for anxiety, are non-psychiatric medications that we use. So our anti-anxiety medications, one of the first ones we tend to think about are benzodiazepines. Benzodiazepines work by increasing GABA, right? GABA, again, is inhibitory, so increasing GABA is calming. They're fast-acting, they work for everyone. However, they're also short-acting. Because of the fact that they're short-acting, if we have someone with a chronic anxiety, constantly giving them benzos, they're going to get addicted. They're going to have tolerance. They're going to need more of the benzo, and honestly, going to use it all day long to fix their anxiety. We do have withdrawal symptoms if suddenly stopped. It is, honestly, some of your two simplest ones. Rebound anxiety, we get even more anxious if we have a benzo addiction once we stop, and then chronically really, really high blood pressure. Benzos can cause respiratory depression, but not on their own. If they're mixed with something, that is where benzodiazepines are concerning, alcohol, opiates. We do have to use caution, though, because of the respiratory depression, because of the sedation in the elderly, those with COPD and sleep apnea. Biggest concerns is that they're addicting. Take them only as prescribed. They can cause sleepiness, right? Don't operate heavy machinery. Same token, we can keep going. They work well for seizures. You don't want to take them with caffeine. Benzos and caffeine are a bad risk because they contradict each other. If we have someone who is anxious and they're taking a benzo, but then they're also tired and drinking caffeine, maybe using a stimulant, Adderall or Ritalin, they counterdict each other, and we might as well not be taking either. Buspirone is a non-benzodiazepine anxiolytic. It does not cause sleepiness or muscle relaxation. It just causes decrease in anxiety, but it takes a few weeks to work. Benzos are PRN, right? They are great for our patient with panic attacks. Give you one to help the panic attack, and that is it. Buspirone, great, but it has to be taken every day. It does not work if we don't take it scheduled. It is not addicting. Our common side effects are headaches, dizziness, and nausea. Now, I've listed a whole bunch of other medications on the right. These are other medication classes that we tend to use for anxiety. And honestly, our first line for a lot of anxieties are going to be our SSRIs or SNRI. So our antidepressants, because of how they work, they also help anxiety. Beta blockers like propranolol is another very common one. It can help PRN. Sometimes it can even be scheduled. It helps a lot with social anxiety. If I have someone afraid of public speaking, a propranolol could be useful. Anticonvulsants, what I see frequently, is gabapentin. Gabapentin is a controlled substance in some states, and I know some of y'all have told me at work y'all are now having to count it. So we do have to be mindful. Antihistamine, specifically hydroxyzine, also known as Vistaril or Atarax. There's two different types of brands of it. That is sometimes used as a PRN, again, or scheduled. It's a little bit stronger than Benadryl, and it helps in that moment. So for depression, we're going to go into, and honestly, they can help with anxiety too. One of our first line medications are our SSRIs. So SSRIs are selective serotonin reuptake inhibitors. They basically block the receptors in the brain and cause your body to have more serotonin available in that synaptic cleft. We can see we have a wide set of uses for these: depression, OCD, PTSD, generalized anxiety disorder, social phobia, premenstrual dysphoric disorder, bulimia, anorexia. The list goes on and on and on. One thing we have to remember with all of our antidepressants, they increase suicidality. They take 2 to 4, 3, 4, 6 They're all vary, but they take a few weeks to work. During that time, if I have someone with depression, their energy is super, super low. As I give them this medication, it's going to increase their energy, but not fix their depression yet. So we see an increased risk of suicidality, especially in our teens and young adults, when we start these antidepressants. So we do have to be extremely mindful of that. Now you can see on the right, I've put some examples of names of what are some of these medications. Our prams and our enes, citalopram, escitalopram, fluoxetine, paroxetine, sertraline. Those are some of our more common antidepressants. I think paroxetine, Paxil is one that we tend to see used a little bit more on questions. Now, as we go with our SSRIs, some of our patient teaching. These are often first line because they have less side effects. We can see do have side effects. It's not that they don't have any. However, they don't have as many. Serotonin is made in our gut, so GI upset is one of our biggest. Often we just let patients know, take with or without food, whatever works for you, and give it a little bit of time. If the stomach upset works in the beginning, after like a week or so, that could go away. Sometimes sexual dysfunction, and we're not going into specifics about these medications, but some of the SSRIs, we see less sexual dysfunction, some we see more. Some we see more, nervousness. Escitalopram, Lexapro is one that we're likely to see a little bit more of that nervousness and restlessness than compared to another medication. So sometimes we can just play around with our meds. One of the things we have to think about is serotonin syndrome. Serotonin syndrome is an extreme risk, high fever, hyperreflexia, upset stomach, GI upset, diarrhea. That happens. Often what happens is our patients are mixing medications. One doctor gives them one med, another gives them another. They don't let the doctor know. Oftentimes we're mixing meds and we don't know we're mixing meds. Some of our SSRIs, along with tramadol, right? If you're on a higher enough dose of both, that can increase the risk of serotonin syndrome because our opiates increase serotonin. Dextromethorphan are over-the-counter cold, flu, cough medicine. They also increase the risk of serotonin syndrome. When we get to the MAOIs, we'll talk about that one specifically. We do have something called antidepressant continuation syndrome, and if you stop your antidepressants suddenly, nausea, insomnia, fatigue, a lot of flu-like symptoms, vivid dreams, nightmares, along with mood changes. So we do have to be cautious in our patients and not have them just stop the medication. We want to taper slowly. So SNRIs, we did not necessarily talk about this in the PowerPoint for this week, but we did talk about this before. These are actually some commonly used medications compared to some of the others, and these are our second line for a lot of things. They are serotonin norepinephrine reuptake inhibitors, so just like our SSRIs, they are increasing serotonin, but we get the bonus with these that we're also increasing norepinephrine. Depression, anxiety, and neuropathic pain, they work extremely well for. Again, increased risk of suicide. Side effects are going to be all of the ones that we see in our SSRIs. However, we are also adding in an increase in blood pressure. Maybe an increase in heart rate, but definitely that increase in blood pressure because of that effect on norepinephrine. Again, we don't want to stop these suddenly, and we might have someone who is on this for pain, not just for depression or anxiety. But often SSRIs, SNRIs, they are our first line for anxiety, and they're going to be our first two choices for depression too. Tricyclic antidepressants were one of our first antidepressants, and a long time ago this was our first line. However, they're lethal in overdose. They have a lot more side effects, so we don't use them that often. They do cause cardiac arrhythmias in large amounts because they block sodium channels in the heart. So these are, again, not ones we are giving often. Sedation, weight gain, orthostatic hypertension, tachycardia, cholinergic side effects are all things that we see. Amitriptyline, nortriptyline, sometimes we will also see those for neuropathic, for chronic pain type disorders. But the big thing for this patient, especially if we're using it for depression, we want to give a 7-day supply. If I'm talking about one of these triptylines, doxepin, I'm going to give a 7-day supply, and then I'm going to give a 7-day supply, and then I'm going to give a 7-day supply. When I know the patient is stable, then I might give a 2-week supply, and then slowly increase up. Now, MAOIs. MAO is a substance in our body that breaks down certain substances to include serotonin, norepinephrine, dopamine, and tyramine. When we inhibit, when we stop monoamine oxidase, our body cannot break down these substances. And not breaking down serotonin, norepinephrine, and dopamine is great because that has a positive effect on our mood. However, the concern comes because we cannot break down tyramine. Tyramine is a substance we find in multiple different types of food. And when we have that excess in tyramine, it causes vasoconstriction, which leads to an elevation in blood pressure and potentially that hypertensive crisis. So these medications are not used very frequently because they are anticholinergic. They have a whole bunch of other side effects. But the big thing, we have a super strict diet. Right? This is that charcuterie platter. Your patient has so many things they cannot eat, and this is even a small list. Wine, beer, aged cheese, chocolates, preserved or pickled meats, smoked meats are also bad. Fermented vegetables, so no pickles, homemade cheese spread, soy sauce, fish sauce, avocados, figs, raisins. It gets super complicated. I have already kind of let y'all know in class, but I'm letting y'all know again, even between your textbook and like the Saunders and Kleck's prep book, there are differences. Yogurt being one of those that is complicated. Yogurt can have a moderate amount of tyramine, so depending on our patient, that also is going to affect it. So what we think about with our patient is we have to talk to them to stay away and limit their consumption of these foods. If they do eat it, we have to be monitoring their blood pressure. Fresh foods are the simplest things to think of that are good, right? Fresh squeezed orange juice versus something else. Oatmeal cookie good, oatmeal raisin cookie bad. Fresh fish good, smoked fish bad. Fresh meat good, beef jerky bad. So fresh food is what we want to steer our patient to. Now, the other thing we have to think about is there are multiple interactions with other medications and MAOIs. If I am switching from an SNRI to like an SSRI, I'm just going to switch. But if I am switching between any one of our other antidepressants and an MAOI, I have to stop one of the medications for 2 to 5 weeks before I restart the next one. We actually have to completely flush out of our system before we start. So if I have a patient on phenelazine, they cannot be on paroxetine. That is a very dangerous risk. Stimulants, dextromethorphan, pseudoephedrine, over-the-counter medication, opiates, they all interact with MAOIs. So we have to make sure our patient is letting their providers know. We have to make sure they know. You have to tell all your providers what medications you are on. Now, one of the risks, and we talked about this very briefly, is serotonin syndrome. It is rare but life-threatening. It is caused by too much serotonin. We often see because we have too high of a dose of a medication, or we have multiple meds that are interacting. We can see our severe symptoms, hyperpyrexia, so super high fever, cardiovascular shock, and death. It often starts as abdominal pain, diarrhea, a low-grade fever. So these patients are going into urgent care and they're like, hey, I'm sick. Hopefully urgent care gets to the bottom of it because eventually we get to altered mental status, irritability, mood changes, hyperreflexes. We have to stop the medication and we provide symptomatic treatment. They list a whole bunch of things that we can do. Most important thing for us to know now, we're going to stop the medication. We're going to provide symptomatic treatment. And we're going to make sure we're educating our patient that we're waiting to move medications, that we are not taking, meds that aren't prescribed, that we're not doubling our dosage. So we talked briefly about lithium today, and lithium could have its whole other separate lecture. Lithium is used for bipolar disorder. It is a salt. We need to monitor our salts, our fluid intake, and our activity level. And we want it to stay consistent. If we're dosing this patient and they're drinking, 2 liters of water today, we want them to consistently drink 2 liters of water. We don't want them to all of a sudden be like, I'm going to be healthy and drink 2 gallons of water today, because that will affect their lithium level. We do have to monitor the lithium level frequently in the beginning and then every few months because it does have a narrow therapeutic window. We'll look at that in the next slide. Lithium toxicity is dangerous, so we need to make sure we're educating our patient on what can affect their lithium levels. Things that can affect it: dehydration, so vomiting, diarrhea, just not drinking enough water will increase your lithium level. As water goes down, sodium goes up. Lithium is a salt. So as water goes down, our lithium level goes up. If our patient decides they're going to drop all their sodium and they eat a diet low in sodium, right, lithium is no longer competing anymore and lithium will increase. If our kidneys are not working, we have to use a special cautious with lithium. And medications that affect your kidneys, salt water. So any of our hydrochlorothiazide ACE inhibitors type, but also NSAIDs, so ibuprofen. Ibuprofen will increase our patient's lithium level. Caffeine is an interesting one because it's going to lower our lithium level. So if we have someone, let's say they feel like they're not sleeping, they're drinking more caffeine, they're stressed, we're going to lower their lithium level. We are now increasing our patient's risk of going manic. These do take a few weeks to work. We have to remember we have some side effects that are not necessarily toxic. Polyuria, right? Excessive urine, lethargy, fine hand tremors. Fine hand tremors are okay. So when we look at lithium toxicity interventions, I copied this straight from your textbook, y'all. 0.6 to 1.2 is where we tend to see our normal levels. Galen tends to say 0.5 to 1.5. Honestly, it's when we come to specific, like in real life, specifying where we want our patients, there is such a range. It is not a specific number for any one person. It depends on what's going on with each individual. The important thing to remember is 1.5 and above is toxic. 1.5 and above is toxic. Now, if we have someone in that 1.2 to 1.5, and honestly, even some of those normal side effects that we see, nausea, vomiting, diarrhea, polyuria, lethargy, sedation, fine hand tremors, so tiny hand tremors are normal. With long-term use, we see thyroid get affected, so we have to be monitoring the thyroid because we have hypothyroidism. Now, our early toxicity is 1.5 to 2. We need to catch this early because if we get to severe toxicity, it is death. And it is very easy to go between. So in that 1.5 to 2, we tend to see a greater upset stomach. We had fine hand tremors at less than 1.5. That 1.5 to 2, we have coarse hand tremors. So our tremors have gotten worse. We are confused, right? Maybe we're sedate. That early toxicity, I want to hold your med, check your blood levels. We always want to push fluids. If we have an increasing lithium level, if our patient can orally take fluids, great. If you are in a place where you can give an IV, even better. We're going to watch the type of fluid we're giving, but either way, we want to fluid load these patients if they have high lithium level, because that will naturally kind of push that increase in water, push their lithium level down. If we don't catch it at that 1.5 to 2 and we go to advanced toxicity, which is 2 to 2.5, now have ataxia, so kind of that gross discoordination. So we started, right, normal fine hand tremors, early toxicity, coarse hand tremors, but now we have ataxia and seizures, right? We have clonus coming in. Our vision's blurred. At this point, our patient should definitely be hospitalized. We have definitely stopped all the medication. We're definitely cleaning out their bowels, flushing their systems, trying to get them good, right? Giving them fluid. Severe toxicity is above 2.5, and at that point in time, you pretty much have convulsions and death. If we have a patient who is still with us and they're at like 2.5, 2.6, we're getting them on hemodialysis. Like, we have to completely get this out of their system to hopefully get them back down to normal. Now, we talked about these before. You can see I put them into one little slide. We have some anticonvulsants. Y'all should hopefully be familiar with these because they also treat seizures and epilepsy. If I have someone with kidney damage, they can't be on lithium, so I might give them an anticonvulsant. Things we have to think about: risk of Stevens-Johnson syndrome. Risk of Stevens-Johnson syndrome occurs with all of these medications. I have seen it. It is one of those where you don't see it often, but I have had an adolescent. When I worked in peds, we used a lot of these medications. Any rash, we would hold the med. If we have someone of Asian descent, we have to do genetic testing because they do have a higher risk of Stevens-Johnson syndrome. Our big side effects are going to be pancreatitis and hepatic failure. So we have to do our labs to monitor our liver and our pancreas. So whole liver function, CMP, all of that stuff at the start of treatment, and then routinely. I'm going to skip a few slides in this PowerPoint because we are not there yet. And I'm going to skip to our antipsychotics. So when we talk about our antipsychotics, we have two different classes. Our conventional antipsychotics are sometimes also called our first generation or our typical antipsychotics. Our atypical antipsychotics are sometimes called our second generation antipsychotics. For the most part, we just kind of need to know we have first generation and we have second. First generation haloperidol is one of the big ones that we see mentioned. That's Haldol. It is of these the one that gets used more frequently. Atypical, all of these kind of get used a lot depending on where you are. Aripiprazole is Abilify, olanzapine is Zyprexa, quetiapine is Seroquel, risperidone is Risperdal. Those are some of the ones I've seen more frequently, but honestly, we're seeing a lot more Ziprasidone and paliperidone. So all of them can be. So things to remember about our antipsychotics. If my slide will skip. Okay. First generation are also known as typical or conventional. These are old school. We don't use them often. They work well with schizophrenia by decreasing dopamine. However, they really only help the positive symptoms. So they're pretty much only going to help our hallucinations and our delusions. All of those negative symptoms that we see with schizophrenia, these do not help them. Because of that blockage of dopamine, we have a whole lot of side effects. We're going to go through all of those individually. Do not worry. Nursing considerations, our big ones, are monitor for side effects, and we use something called an abnormal involuntary movement scale. So, it's not from your textbook, it's from a different one. However, it kind of spells out what we see in some of these side effects. We are going to go through and talk. So we have our normal and our not so normal side effect. Our normal side effects are a lot of those anticholinergic. We're constipated, we have blurred vision, our eyes are dry, tachycardia, I'm having urinary hesitancy, right? Dry eyes, dry mouth, can't see, can't pee, can't spit, can't poop, all of that stuff. Sedation and weight gain are also two big ones with all of our antipsychotics, and these patients can gain weight. That is a big one. But those are side effects that I'm not necessarily calling the doctor for. We almost expect some of these side effects to happen. We do have a huge list of not so normal side effects that we see with antipsychotic. EPS are extrapyramidal symptoms. Those are our movement side effects. That has to do with the fact that we're disrupting dopamine. Increase in prolactin. What that means is, and I've seen this, I have had a teenager who all of a sudden, she was not pregnant, she did not have a kid, she started lactating because of, for her, it was risperidol. She was on a second generation antipsychotic. All of a sudden, she started lactating. Men can grow breasts, men can lactate. Women who are not, having kids at that point in time can lactate. NMS, metabolic syndrome, the rest of these, we're going to talk about them throughout the slide, and we're even going to what our EPS is, because EPS is 4 different symptoms. We have 4 different conditions that we see in EPS, and our first one is akathisia. I'm going to mute this, but just so y'all can kind of see it in the background as I'm talking, if it will play. Akathisia is a hard one because it appears as an increase in anxiety, this inner restlessness. We have this patient, they have been super anxious. I give him a dose of Haldol, and all of a sudden they are more anxious. It looks like my videos are not going to work. The patient cannot sit still. They have this inner restlessness. They're constantly moving about. This is a hard one. We don't necessarily want to stop the patient because we're not going to be able to. If we put them in a chair, if we lay them down, their legs are still going to be going. We have to recognize that this is a side effect and not administer more of the medication. We can do some IM Benadryl to kind of help chill them out. Oh, wait. Are we going to play real quick? Either way, so we can see like in akathisia, they have this child, and this is nausea medicine. Phenergan can cause this, Reglan can cause this, not just our antipsychotics. But this kid, he is sitting, his legs are going, he is physically unable to stop his legs. He will keep moving. No matter if you were to stand him up, he'd be pacing, like he'd be wiggling. He cannot physically stop. So pseudo-Parkinson, I know we watched this in class. We have a video. So Parkinson's, Parkinson's as a disease on its own is caused by low levels of dopamine. Our antipsychotics are leveling dopamine, so we have something called pseudo-Parkinsonism or drug-induced Parkinsonism. So these are temporary. When we stop the medication, these can stop. And sometimes old school, we would hear this called the Thorazine shuffle. They are stooped, they have rigid movements, they're moving slow at times, they have tremors at rest, and they got the pill rolling. Kind of like how his hands are going, thumb and fingers are going in between. We call that pill rolling. We want to start the medication, and we want to give some cogentin. Cogentin is also benztropine. It is a Parkinson's med. We use it very frequently in mental health with our patients who have EPS. So acute dystonia. This one is it's not dangerous, but it's scary. It is acute, so it comes on suddenly, and it has stone in it, dystonia. So we're going to think this turns you to stone. We have someone who is anxious. We give them an extra dose of Haldol. They've been doing okay on their steady dose, but we increase their dose. We give them that extra, and all of a sudden their muscles contract and their muscles will not relax. They are having muscle spasms, face, neck, and back, facial grimacing. They are just like, this guy is frozen. An ocular gyrate crisis is when our eyes are fixated at the ceiling and we cannot move our eyes. It is scary for our patients, but most of the time it is not dangerous. It will only be dangerous if the airway is affected. In that case, we call 911. If the airway is not affected, which a lot of times the airway will not be, we are going to IM Benadryl and IM Cogentin, IM benztropine, and it should quickly resolve. We do have to remember it can produce a lot of anxiety in our patient, so we need to stay calm. We need to get them the Cogentin and the Benadryl. So tardive dyskinesia, this video goes on for a very long time. Let's see if it'll let me skip to some of them. And it is kind of a good example of what we see in tardive dyskinesia. So tardive dyskinesia can be very disfiguring or incapacitating for our patient. It's not going to kill them. However, we can see 25% of patients with long-term antipsychotic use will have tardive dyskinesia. And what this is an involuntary repetitive movements in the body and the face. It starts off very mild, and then it progresses into very severe. Again, antipsychotics are not the only ones. We often see this with like Reglan, Compazine, Phenergan, because they affect dopamine too. However, we tend to see a chewing motion, this tongue sticking out, sucking and smacking of the lips. So we can see like this individual right here on the screen where her kind of lips are pursing back and forth. That is one of the symptoms of tardive dyskinesia. He kind of has it a little bit worse. We can kind of see heads moving, his chewing his lips. We got the kind of jerking of the face. Those are going to be some of those symptoms of tardive dyskinesia. This is and historically has been irreversible. Once we get tardive dyskinesia, it does not always go away. So that's why tardive dyskinesia is often a priority. We have to recognize it early in our patients. We want to recognize it early, and we want to be able to get one, either medication change, or two, Cogentin on board. Historically, we would give benztropine to kind of work again to even out that dopamine. We do have some newer medications, and I cannot pronounce them. Ingrezza and Austudio, valbenazine and deutetrabenazine. They can work to help some of this tardive dyskinesia. They can cause QT prolongation and sleepiness, which so can the medications. However, we do just have to very closely monitor for them. Neuroleptic malignant syndrome is seen in first-generation antipsychotics and is caused by an excessive dopamine blockade. So excess dopamine causes neuroleptic malignant syndrome. It is a sudden high fever, and when we talk high fever, we're talking like 107. So your patient will all of a sudden present 107, altered mental status, their muscles are rigid, almost like a delirium, they're confused, they're incontinent, they're wetting themselves. We stop meds, we call 911. They need greater support than we can do generally in mental health. It will be fatal in 6% of cases. Organ failure, sepsis, rhabdomyolysis, kidney injury, respiratory failure are usually going to be what's going to kill the patient. So our second generation antipsychotics. So these are used more frequently. So these are our first line antipsychotics. So our second generation antipsychotics are our first generation antipsychotics. These are our new ones. They increase serotonin and dopamine, and they have an effect on both our positive and our negative symptoms. So the positive symptoms was the psychosis. The negative symptoms are the anhedonia, the apathy, the avolition. Affecting that negative symptoms too can be extremely helpful. They have a ton of side effects. EPS, so remember EPS are 4 symptoms: akathisia, acute dystonia, tardive dyskinesia, and pseudo-Parkinson. We do have a risk with our second generation, with our atypical antipsychotics, but it is a very, very tiny risk. I don't think I've ever had a patient who has had EPS from second generation antipsychotics. Now, metabolic syndrome, anticholinergic toxicity, definitely have seen these in our patients. So the big one that we tend to see in atypical antipsychotics is metabolic syndrome. They cause weight gain. And some of them, olanzapine, Zyprexa being one, can cause a lot of weight gain. I mean, we're talking sometimes like 30, 40 pounds. These medications cause the patients to go. We also tend to see increase in lipids and increase in blood sugar. I have had adolescents where we were doing monthly blood sugar checks, and blood sugar's good, and all of a sudden we're like, dude, you're pre-diabetic. And really the only change was the antipsychotics. So we have to look at that. Metabolic syndrome increases our patients' risk: hypertension, cancer, diabetes, cardiovascular disease. And our patients with schizophrenia are already more likely to die from these conditions. So we have to make sure when we are talking about these second generation antipsychotics that we are monitoring, right? Weight, blood sugar, lipids, all of the basics, just to make sure. Now, agranulocytosis. It can happen with all antipsychotics, but it is more likely to happen with one called clozapine or Clozaril. And Clozaril, it is our most effective antipsychotic, but it hardly ever gets used. I think I've only ever seen 2 patients on it. It has a black box warning. You need a special doctor. Not every doctor can prescribe this medication. The doctor has to be registered. You have to have a special pharmacy because you need weekly blood draws for the first 6 months. So granulocytes are a type of white blood cell. Agranulocytosis, we're taking away those white blood cells and we are causing neutropenia. So this is a drug-induced neutropenia. We are doing weekly blood draws for 6 months, every other week blood draws for 6 months, then every 3 to 4 weeks for 6 months. If we can go 18 months on clozapine without any issues, the risk drops drastically. However, our biggest nursing interventions are making sure the patient knows if you are sick, you need to call your doctor and we need to do a CBC. We have to monitor that CBC with this medication. What is the absolute neutrophil count? What are their white blood cells? If this patient all of a sudden is like, I'm tired, I have a sore throat, I just don't feel good. Hold the med, draw some labs. It is very much a better safe than sorry. So anticholinergic toxicity, our anticholinergic symptoms, right? We're going to think dry eyes, dry mouth, can't see, can't pee, can't spit, can't poop, where everything kind of dries. Anticholinergic toxicity takes this a step forward and it's potentially life-threatening. I have seen this, and it's usually in patients who are on multiple different medications. My patients who are on an antipsychotic and had a history of a benzodiazepine abuse. So for these patients, one of the big things we see in mental health, their psychosis was stable, the psychosis is getting worse. Delirium, urinary retention. We are sending these patients out for catheters. And it sounds funny to say that we're sending them out for catheters, but we don't do catheters in mental health. I'll send you to urgent care to get a catheter, and then we'll bring you back to monitor them. We do have to make sure we are monitoring for this, that we're holding the medications, and that we are just overall monitoring our patients for any changes to their system. That is it for medications. I know it was the longest, but we did cover a few different groups. If you have any questions, let me know.